It has been said that it's better to ask and discuss than to assume. So with that thought, let us proceed towards our panel discussion on topic peripartum hypoxemia. For our panel discussion, I would like to invite our moderator, Dr. Dipak Viradia, interventional pulmonologist, intensivist, and ECMO specialist. He is currently affiliated with Director of Unique Hospital, Unity Hospital, United Green Hospital, and Mangaldeep ICU Hospital, teaching faculty of IDCCM and DNB Respiratory. His area of expertise is ARDS, ECMO, airway disease, obesity related breathing disorders, and etc. I now invite our panelist, Dr. Nitin Raithatha, Professor, Department of Obstetric and Gynecology, Pramukhswamy Medical College, Karamsad, Dr. Bhavin Gaur, Consultant Intensivist, Ahmedabad, Dr. Haresh Vasropara, Consultant Intensivist, Surat, Dr. Mahesh Sutaria, Consultant Intensivist, Surat, Dr. Bhavin Gaur, Consultant Intensivist, Rajkot.
Good morning to all, and first of all, happy ISCCM day today. And I congratulate ISCCM Karamsad for organizing such a nice event. First of all, we are starting today with peripartum hypoxemia. Before going for a peripartum hypoxemia, as I mentioned that pregnancy is always be a surprise for a husband and wife, or sometime other than other person also. So pregnancy is always a surprise. For a doctor, pregnancy also a surprise. It is the only or maybe one of the physiological condition that is a high risk for every disease. So if you see in a doctor's life, only a physiological condition that make a person high risk for so many diseases. In a medical history, as sir has mentioned, whenever we take a history, one question is, are you pregnant? Because there are so many equations are changed because of pregnancy. So all the drugs equation changed, all the investigation equation are changed. So pregnancy is the important aspect of every disease. Today what we are focusing is peripartum area. So in specifically for peripartum area, I am starting my panel discussion. I have for my colleague Dr. Nitin, who is a gynecologist, Dr. Bhavin, Dr. Haresh, and Dr. Mahesh Sutaria. All three are very well intensivist, and my friend. It's more of my family get together here because all we are colleagues and friend here. So first of all, I want to ask Dr. Nitin. As I mentioned, there is pregnancy is always a special condition. So what do you think, why pregnancy is such a high risk for specifically for hypoxia?
As sir has started the first bowl in the morning, the Antani sir, the special things are there with each patient as a part, but pregnancy is not one patient, it's a two patient. So two physiologies going simultaneously, and anatomical changes and physiological changes along with the biochemical changes together makes it a more unique. As a part, enlarging uterus, and particularly when we talk about the peripartum part, so the diaphragm is being pushed up, the lateral expansion of the chest, along with hyperemia, more secretions, estrogen, progesterone on a high level, changes all the normal range in a different part. For example, residual capacity will change, overall rate of breathing will increase. So all these changes makes it unique. At the same time, the gradient is always in favor of the newcomer, that is a fetus. So whatever the changes are welcome changes, so in a part, mother is remain safe, at the same time growing fetus to whom the oxygen is the main drive to grow, that is the what required.
Yeah, there are so many respiratory and cardiological changes are there with a pregnancy. Dr. Barin, is there possible that physiological hypoxia is possible in pregnancy?
Yes. We should be knowing before managing hypoxemia, we should be knowing what are the physiological changes that makes pregnant patient vulnerable to hypoxemia. Like as sir has described, first respiratory changes, reduced functional residual capacity, and compensated respiratory alkalosis. Most of the time patient is hyperventilating, that is very common, and in compensation to respiratory alkalosis, kidneys excreting more bicarbonate. So these patients are not a good candidate to compensate for metabolic acidosis. One more thing is hemodilution. Blood volume is increased, cardiac output is increased, stroke volume is increased. So these patients are at risk of congestion also, at the risk of fluid overload also. These things make patient vulnerable to hypoxemia, particularly in peripartum period. Other changes like patient is at the risk of aspiration because of the reduced gastroesophageal tone and delayed gastric emptying. That is important during the peripartum period and during labor and while we are intubating the patient. One more thing is immunosuppression of the pregnancy that makes patient vulnerable to viral infection, particularly cell-mediated immunity is low. So viral infections present with the more severity compared to non-pregnant patient. And last one is other hematological changes and prothrombotic state. These patients are more vulnerable to develop DVT and pulmonary thromboembolism. These are the changes that are relevant to develop acute hypoxemia. So we should be more cautious when we are dealing with the peripartum patients.
Yeah, so definitely there is a high risk for hypoxemia. Physiologically, hypoxia may not be possible, but there is a definitely patient of pregnant patient is very high risk for hypoxemia. There are so many cause behind hypoxemia throughout the pregnancy, but today's topic is peripartum. So what we are focusing today is more of peripartum period hypoxemia. So what are the changes as already mentioned? So what are the causes which cause the hypoxemia during the peripartum period? So how you define, Dr. Haresh, how you define the different type of causes in a peripartum region, period of pregnancy?
Good morning everyone. First of all, there is always physiological hypoxia in a pregnancy. In peripartum period, we discuss about the pathological hypoxia. So many factors that cause hypoxia during the peripartum period. First of which is the cardiac cause. Sometimes there is a cardiomyopathy, myocarditis, pericarditis. This all cardiac cause of some congenital heart disease. They may be aggravated during the third trimester of the pregnancy. Other cause like some valvular heart disease. Initially we know, but patient is not taking proper treatment, or during the pregnancy this valvular heart problem will exaggerated. This all cardiac cause can cause peripartum hypoxia. Second, respiratory point. In a respiratory point, there is a high chance of the pulmonary embolism, amniotic fluid embolism, acute exacerbation of the bronchial asthma if the patient is not correctly treated, high chance of the aspiration pneumonia, high chance of this all, because basically already Bhavin says pregnancy is a immunocompromised state, so high chance of the viral infection, like whatever the coronavirus, swine flu virus, there is a high chance of the viral infection in a pregnancy. Same way, high chance of the bacterial infection in the pregnancy. That all cause hypoxia, usually pathological. After out of these two, other like pregnancy point of view, some amniotic fluid embolism, or other many like thyrotoxicosis or other cause, that all cause peripartum hypoxia.
Yeah, so there are so many causes are there. There are certain causes that are pre-existing, like valvular heart disease and all. They are pre-existing, they are worsening. Certain causes are new, viral infection and all. Certain causes are specific to the pregnancy, like amniotic fluid embolism, pulmonary embolism. They are all are specific. So, and one of the some unusual cause like trolley and all thing, because there is chance that patient requiring the multiple blood product transfusion. So how is the experience of incidents, and how is the presentation of trolley in peripartum region? Just enlighten us, Dr. Mahesh Sutaria.
Yes, good evening, good morning everyone. As you sir tell, pregnancy is a surprise. So trolley and blood transfusion is also many times surprise for us because of sometimes we not anticipated peripartum bleeding like abruptio placenta, intrapartum bleeding and postpartum bleeding. Many times emergencies happen in middle of the night and investigation was not on our hand, and because of genuine emergency, surgeon is doing the procedure and intraoperatively there is a massive bleeding and havoc situation is happen. That time is very difficult to manage that patient, and we have a limitation of resources. Many times we don't have a monitoring tools is on table. We don't have a arterial line inside the arterial line catheter is not placed. So in this situation, many times our anxiety is working, and because of anxiety we are transfusion, so many over transfusion is done, and its availability of blood product not properly available. So because of that situation we are doing the over transfusion or miss transfusion, and that can causes acute lung injury, and that is a trolley, and trolley can causes hypoxia and very difficult to manage that trolley. My personal experience, whenever the requirement of transfusion in obstetric cases, if it is happen before the it happen after the OT, that is maybe many times patient was in ICU, that is less chances of over transfusion and mistransfusion. But if happens in inside the operation theater, that is possible if we are doing the over transfusion and we don't have any exact monitoring tools. So it's required to know proper pre-operative evaluation and exact availability of the required blood products that can prevent the trolley.
Thank you. There are so many causes are there, but I think peripartum period are more prone unusual thing. For a critical person, as per a critical, we should know about some unusual, less common cause first, like amniotic fluid embolism, pulmonary embolism, cardiomyopathy. They are the three main cause that can be precipitated at any time. So, Dr. Nitin sir, how frequently you find all these three cause in your practice in gynecological perspective?
Yes, the trend is a different part, and major part is the nutrition, particularly in our region, Charotar region. Somehow B12 deficiency is quite different. At the same time, protein malnutrition is there as a part, and along with this, preeclampsia and anemia, these together give a load to the heart, and we see quite often cardiomyopathy. So if we specifically were to define peripartum cardiomyopathy is a different thing, but diastolic dysfunction is quite commonly seen in our practice, what we are seeing as a part, particularly patients who are of preeclampsia.
So if we assess, if a gynecological point, if patient is in a distress in peripartum, how you proceed from your point, OBG point, how you proceed? Like in critical point we will going to proceed by our flow, but as a gynecological in your nursing home, how you people are doing your procedure?
So as again go to Antani sir back as a part, history taking, the proper clinical examination gives us a many part, like simple physiological dyspnea of pregnancy that we have to rule out first as a part, whether it's a physiological or pathological. Once we differentiate that part, when it's a pathological, then it's a lung origin or cardiac origin. Once we differentiate it, seems there is no respiratory part is involved, is mainly related to cardiac. And then we have to evaluate the cardiac part, and the best thing what we approach is go for the echocardiography. Along with basic vitals, examination SpO2 nowadays is a routine practice we have adopted as a part. So that is what we do in the routine OPD practice, just to screen part. In case of emergencies, again, early warning score, Muse scoring helps us to detect these patients changing. And in such patient, as particularly mentioned, severe preeclampsia, severe anemia, and Muse score is high, we always go for the echocardiography. Yeah. At least screening echo is always useful to give some idea.
So always, like if patient is a preeclamptic, nutritionally deprived, you be ready for this type of complication. Yeah. So Dr. Bhavin, if as per my clinical knowledge, to diagnose a amniotic fluid embolism is very difficult, first of all, and to treat is more difficult. So how you proceed? if you think of, if your mind is thinking of amniotic fluid embolism, how you will proceed in your patient?
See, amniotic fluid embolism is catastrophic event, but it is not so common. It is very rare. Keeping in mind all the other differential diagnoses during the peripartum period, like they are more common. So, hypoxemia evaluation and treatment should go hand in hand. Like we should start with the supplemental oxygen, and if patient has severe hypoxemia, as we are talking or we are dealing with the severe hypoxemia more commonly as being an intensivist, so intubate the patient properly. Fetal hypoxemia should be avoided while we are diagnosing the case. So targets of the oxygenation are also different. We should keep PO2 higher than the non-pregnant level, and we should keep ventilating the patient with the target of PCO2 of 30 to 32 around. And while we are managing this patient according to the history and presentation, we can define or we can narrow down the differential diagnosis. First and foremost is for amniotic fluid embolism, it is always a sudden onset. It is very much acute. Like compared to postpartum cardiomyopathy, usually it is a subacute onset, not very much acute. So we have two common differential diagnoses, like whether patient has pulmonary thromboembolism or it is amniotic fluid embolism. And there are one or two major criteria that define or that goes in favor of amniotic fluid embolism. In one of them is presence of DIC, early DIC. DIC is very common in other diseases related to the pregnancy, like abruptio.
Is there any definitive investigation is there?
A definitive investigation, it was once it was considered that if you find out amniotic fluid and fetal cells in the pulmonary artery, distal part of the pulmonary artery, and that can define, that can diagnose amniotic fluid embolism. But it is nowadays it is not very much accepted, because in some normal patients also you can find this. So more or less it is a diagnosis of exclusion, ruling out other pathologies, and then you can define that this is more likely a amniotic fluid embolism. So we don't have much time. CT pulmonary angio, and we do not be afraid about the radiation hazard. Whenever in diagnosis or doubt, you go for the CT scan and CT angio to rule out thromboembolism also. But presence of DIC is very much hallmark of this amniotic fluid.
Just to add part, most of the time these are the intrapartum and postpartum patients. Usually pulmonary embolism is quite commonly seen compared to the antenatal part. And as a dramatic change in the situation where we have to suspect it may not be breathlessness, but sudden dramatic situation, frank DIC suddenly without any specific reason is the suspect that there must be some embolism as a part, along with sudden changes in the vital situation.
Yeah. So there is
actually it is not embolism that is causing problem. That is not a mechanical obstruction of the pulmonary artery that is causing a problem. That is because of the vasoactive substances released in response to the inflammation and response to the antigenicity of this amniotic fluid, and that causes pulmonary vasoconstriction and pulmonary and right heart failure.
That is the problem. Now second thing is, we are, see, if whenever pregnant person is coming in ICU, next worrying factor is investigating. As sir has mentioned, we are over investigating in ICU, but certain time we doesn't have a time, so we are asking so many investigation together. So Dr. Haresh, if I want some patient of suspected of pulmonary embolism, how you will diagnose? And if I want to do a CTPA, are you agree with CTPA or you are refusing for that?
As per full-term pregnancy, if we need imaging like X-ray, CT scan, I am always prefer to go X-ray or CT scan, because there is no so much harm doing the X-ray or CT scan to the fetus. Usually in second trimester, I am usually avoid to doing the X-ray or CT scan, but in the full-term pregnancy, I always prefer to the X-ray or CT pulmonary angio if I am a diagnosis like pulmonary embolism. Other investigation you says like a D-dimer. Usually D-dimer in out of all pregnancy usually slightly higher side upper. So I think D-dimer is not that much significant value for diagnosis of the pulmonary embolism. Echocardiography is one of the very good diagnostic tool for the diagnosis of the cardiomyopathy. a specific point of view. Usually in pregnancy, slightly in cardiomyopathy or either embolism, usually right atrium and right ventricle mildly dilated or enlarged is there. Doppler and this all are later on. Once with our diagnosis is confirmed, we can consider to the bilateral lowerly venous Doppler for the finding out the deep vein thrombosis.
So in full-time pregnancy, radiation is not issue as such. Hypoxia is more worrying than radiation. So always deliberate for a radiological diagnosis whenever required. So never hesitate to do a CTPA angio if you are suspecting pulmonary embolism. Now see, pregnancy is a different issue. Now we see whatever emergency is there in ICU, there are certain protocol is there. First, inotrope, fluid, antibiotic, certain supportive thing. But for a respiratory and the hypoxemic patient, what we need is ventilatory support. So in routine hypoxic patient, we have a threshold of to start with NIV. Dr. Mahesh, do you think rather than putting pregnant patient on NIV, whether to go ahead with intubation?
Yes, because of, as sir mentioned, so many physiological changes in pregnancies happen, and many risk factor for the aspiration and more chances of hypoxia. So whenever you have a dilemma to in between NIV and intubation, is a thumb rule of critical care, as I am preferring the intubation is better than the NIV, as same in our general critical care patient, but threshold for intubation should be lower in a pregnant patient as compared to the other routine patients. So I will put patient on ventilator with intubation rather than the NIV.
Yeah, there is threshold for intubation should be lower than, because high chance of aspiration, high chance of hypoxic fetal injury is there. So always keep a lower threshold for intubation. Second thing, Bhavin, what do you think about proning in a pregnant patient, full-term pregnant patient, hypoxic, not maintaining NIV, so intubated, not maintaining on intubation, whether to go with proning?
Practically, I have never prone a pregnant patient.
Anyone have any experience of pregnant patient on proning?
Yes,
Yeah,
proning
sir,
can be done.
Any your experience?
On HFNC and manage them successfully. And regarding proning, we did try, especially in the first trimester and the second trimester, we did try proning, and even awake proning, and we did receive decent enough results. But HFNC,
Not I'm telling of awake proning. This is
I'm
ventilated.
that's what I'm saying.
proning.
Both. I'm saying both.
Yeah.
Both ventilate, awake proning, and
Is there any
proning.
specific
Yes,
arrangement you have to made for
No,
a pregnant
obviously,
patient with
obviously you just have to. We did not prone any patients who were on in the third trimester. So only the first and the second trimester patient we prone.
Yeah. Second thing is permissive hypercapnia. So this is our rescue medicine, because when we are intubated, refractory hypoxemia, proning and permissive hypercapnia, that we use to do a to rescue thing before going more invasive thing. So Haresh, what do you think about permissive hypercapnia in pregnant, full-term pregnant?
Full-term pregnant patients, once we intubate and start after refractory ARDS, we done every measure, and still patient is not optimizes oxygenation and carbon dioxide. I am still not go to the permissive hypercapnia in pregnancy. My threshold in a pregnancy in a peripartum period is PaCO2 is usually less than 35 or between 30 to 35. Because if we are giving the permissive hypercapnia, there is a high chance of the fetal respiratory acidosis. So I against the permissive hypercapnia.
Yeah, definitely, because in ARDS in pregnancy, threshold for PaO2 is higher, PaCO2 is lower as compared to the normal people. So we should keep in mind that in pregnancy we are ventilating pregnant woman with fetus. So we need to keep a PaO2 higher than normal acceptable, our acceptable PaO2, and we should keep a CO2 less than 35, around 35 for because we are ventilating both mother and child. So that to be keep in mind. Now if patient is in hypoxemia, intubated, not able to prone, not able to permissive hypercapnia, now there is no option. Now last option remain is a ECMO. Now Bhavin, what do you think? Will do
Just-
ECMO?
one part before.
Tell me, sir.
Here we can have option of termination of pregnancy.
No, that
That
will
is-
go. Yeah.
That because to keep the child compromised, the mother compromised, both the part.
Yeah.
So if the child is mature, though it is not term,
Yeah.
but it's more than 35 weeks,
That is-
in team building, communication with the neonatologist, obstetrician and the intensivist together, they can always decide for early termination of pregnancy, and that will improve all the physiology, and it will save both mother and baby both as
That
a
is
part,
the
rather than compromising.
That is the good point. Whenever full-term pregnancy, patient in a distress, don't wait. If possible, deliver the child and manage the patient according to normal. So whenever the patient is full-term and a child is viable and able to deliver it. That is the good point.
Regardless of the etiology.
Regardless
Regardless of the etiology, go for the delivery.
Now, Bhavin, what about the ECMO? Such ECMO is very difficult in ARDS and all. Now, already patient is full-term pregnant. Already intra-abdominal pressure is high. What about the VV ECMO in ARDS, refractory hypoxemia? What sort of difference between the normal patient to the pregnant patient?
Can be done, and even threshold for this ECMO is even lower in pregnant patient because fetal hypoxemia is added entity compared to non-pregnant patient. So we can go for VV ECMO with few technical problems like as we know that cardiac output is on higher side, so we need to keep ECMO flow on higher side, and to achieve that flow we need large bore cannula or sometimes even two draining cannula. And one more problem is gravid uterus is causing this aortocaval compression, and it may lead to inadequate flow for single cannula, and we may need one more cannula in IJV, or you can use double lumen cannula like Avalon cannula in IJV. And one more problem with the ECMO in pregnancy is anticoagulation. As we know that ECMO we need continuous anticoagulation, and we usually use heparin. Heparin does not cross placenta, so it is not a problem for the baby, but there are other problems like postpartum hemorrhage, and there are many other bleeding complications. So we need to keep anticoagulation target toward the lower side, like we keep ACT around 160 to 180, and we try to maintain platelet count more than 50,000. And third thing is about delivery. Even on VV ECMO, you can go for cesarean section with the heparin-free ECMO for even 24 hours also.
So, during the delivery, what are you doing with heparin? Are you continue with heparin?
So, whenever we are using low molecular heparin, it can be stopped 24 hours before the delivery, particularly when you are going for spinal anesthesia.
Okay.
And if it is not possible to go for low molecular heparin, and if it is not possible to discontinue it for 24 hours, then we can switch over to unfractionated heparin infusion, and that can be stopped 4 to 6 hours before the surgery.
Yeah. The last question. There are so many drugs are going, like so many sedative, so many antibiotic. Any like sedative modification, heparin modification, is it required during the peripartum period when patient is on ventilator, intubated, high PEEP?
Particularly when we are dealing with cardiac patient, suppose when we are dealing with cardiomyopathy patient, and patient is in arrhythmia or so, and we can have some like problem with, we cannot go for long-term amiodarone, that can lead to neonatal hypothyroidism and other toxicities. We can go for some selective cardioselective beta blockers, particularly in cardiac case. While in this topic antibiotics is, I don't think it is relevant, but we can routinely we can use midazolam and fentanyl for cases who are being ventilated with high PEEP or patient who is on ECMO, because they need that type of sedation, with keeping in mind that after delivery neonatal respiratory depression is very common, and baby may need to be ventilated for 1 or 2 days. You can use it safely. And one more thing is dosing. Because the volume of distribution is high, like hydrophilic medicines, they need to be loaded and maintained with the higher doses.
So thank you very much all the panelists. And last thing is, the take home message is, pregnancy is high risk. Whenever you feel, deliver the patient. There are the certain parameters, they are different than the normal people, like normal patient, PO2, PCO2, even in ECMO, ventilator parameters are different. So whenever pregnant patient is there, you have to treat like that. Other thing, I already discussed almost whatever possible in this little time. Thank you very much. Thank you very much, ISCCM Karam sir. Thank you very much.
I would like to thank our panelist and moderator for this interactive discussion session. It's not only the answers but also the questions which enlighten us. So if any questions, they are most welcomed.